I guess a few more minutes and then I begin with the
I think it's time.
Is that okay?
I think Meenakshi, we can start.
Okay, all right. All right. So, good evening. Very warm welcome to all the speakers and the moderators. And thank you so much for being here. I'll just begin with a short introduction of why we are having this meeting. So, this is the AWR Surgeons Community Women's Wing, and it is the initiative to talk about the journeys of two women we hugely admire, and the session to be moderated by two women we have, like kind of, we have come to depend on them, we look up to them, and we learn from you. So, introducing the first moderator, Dr. Jyotsna Kulkarni is the first lady surgeon in the world to perform a laparoscopic cholecystectomy. She did it in the year 1990 in the city of Pune. She also started the first animal lab in India in 1992, and she has been responsible for training so many surgeons. She is, of course, an invited faculty nationally and internationally since 1991 and has so many publications to her credit. A leader par excellence, she is trusted by all, and she has always been not only a passionate but a very kind teacher as well. She has received the Sushruta Award in 2015 and has also delivered the prestigious Dr. G.M. Phadke Oration in Massicon in 2018. Her list of achievements goes on and on, but I'll stop here and move on to the next moderator, Dr. Vandana Soni. She's everybody's favorite. She's currently the director at the Max Institute of Minimal Access, Metabolic and Bariatric Surgery at Max Hospital, Saket, New Delhi. This department is known for their high standards, and along with performing high-end complex laparoscopic surgical procedures, Dr. Vandana has a keen interest in teaching and training. She has over 110 national and international publication articles to her credit, as well as a few books on endohernia repair. And of course, she has been given the award of designation of Surgeon of Excellence for Bariatric Surgery by the Surgical Review Corporation, USA. So over to both the moderators, and we'll begin with the session now. Thank you.
So I think the first speaker is going to be Aparna.
Yes.
So thank you so much, Meenakshi, for that kind introduction. And it's really my pleasure to be introducing Aparna Deshpande today. She has, we have a long association, and it's been amazing to see her blossom the way she has. And I'm really proud to introduce her as Professor of Surgery at GS Seth Medical College and Nanavati Hospital. She also is a visiting consultant in both at KEM Hospital and as well as Nanavati. Her areas of interest include hepatobiliary, pancreatic surgery, advanced laparoscopy, and endoscopic hernia surgery. She has been an Executive Council member of the Indian Association of Gastrointestinal Endosurgeons and has also served as treasurer previously in the Maharashtra chapter of Association of Surgeons of India. She has more than 40 publications to her credit, and she's also a reviewer of international journals and national journals like JPGM, International Journal, Indian Journal of Surgery, and Indian Journal of Gastroenterology. So very proudly, Aparna, over to you. Let's begin your talk.
Ma'am, you're muted.
Yeah, shall I share the screen?
Yes, please.
Okay, so So when Meenakshi invited me for talking in this program,
Women
uh,
Surgeons of India.
hello. Yeah, so when Meenakshi told me that it could be any topic of your choice, but it has to be related to hernia surgery, I did not know what a tough job that I was undertaking. And here we are about my hernia story and the challenges that I have faced over the years regarding the same. I will begin with this declaration of my affiliation to these twin institutions of GS Medical College and KEM Hospital. Uh, and I owe everything that I have in my surgical career to these institutions. Dr. P.K. Sen was the illustrious head of first chair of the Department of Surgery, and thereafter there have been great stars in this department like Dr. Bhale Rao, Dr. Bapat, and Dr. Mathur, who primarily have been GI surgeons, and it is a little surprise that primary practice that we have is major HPB and GI work. And therefore the role of hernia surgery as we were growing and I was training in residency or in my earlier years as a staff member was especially with inguinal hernias were cases to start the OR with, which were excellent training opportunities for first year residents, and there were fillers between major cases till the bosses would arrive. So essentially, when the revolution of endoscopic inguinal hernia surgery happened, we really had to wonder whether we had to venture into it. There were a lot of philosophical questions. There were practical issues like compromising the rest of the OT list because it was going to take time to train ourselves, and it was going to take away some of our residents cutting, which invariably makes them pretty unhappy. So overcoming these questions, the learning curve, if at all you would like to call it, in my unit for endoscopic inguinal hernia surgery went something like this. So one had to find an ideal patient, an ideal OT list so that the other cases don't get compromised, and an ideal domestic situation. So this is something I think Barbara might identify, or most women here may identify, that there was a particular period of time when I used to feel that every time I put up a patient for inguinal hernia surgery, my youngest son would have a flare up of his bronchial asthma. So there was a period of 2 to 3 years that I really felt that I'm never going to progress in endoscopic surgery. But suffice to say that over a few years, overcoming all the technical challenges, sometimes very poor optics, sometimes poor case selection and various other problems. A good amount of proficiency was gathered in both TAPP as well as TEP. And I am very satisfied to say that in spite of all the problems and all the major issues, I always insisted on a completeness of dissection, cleanness of dissection, and thankfully none of the major hazardous complications which are associated with endoscopic hernia surgery I had to encounter. Though I did face a lot of challenges in the OT because it would take time to begin with, but I think that was fair enough in the end when you could give a good result to the patient. However, when it came to ventral hernia, because of the possibility of avoiding skin surgical site infections, it had a great appeal. And therefore, accepting a laparoscopic ventral hernia repair was much easier for me. And IPOM, in fact, we started doing very, very early, and the standardization of the procedure was carried out very well with safe access being the primary aim, and then good adhesiolysis, complete reduction of contents. And I always insist on removing all this peritoneal lining of the sac, which is above the sheath, as much as is possible. We know that my entire 100% of it is not feasible, but a complete peritoneal resection, a good wide mesh overlap with peripheral tacking, and then double crowning. So IPOM was something that got established pretty well. But there was always a question of what happens to this mesh that we put inside the patient's body. And somewhere in the mind, these questions were always there. Luckily, very early on one of the operated patients who had a very wide appendiceal scar and a muscular separation, as you can see, with an interparietal hernia, which was sutured and a mesh was inserted as a bridging kind of a repair. This was very early on, maybe sometime in 2013 or 12 or 13. And in this patient, I had the opportunity to do a relaparoscopy for a supraumbilical defect, which was earlier suture closed by us in the first surgery. And I was happy to note that actually the mesh was quite well in place. It hadn't shrunk, it hadn't migrated, but it was absolutely not true that there are no adhesions. So adhesions were there. The only solace was that they were not really dense and they could be separated. And this gave a little confidence with the usage of intraperitoneal mesh, and also a little more confidence to offer maybe intraperitoneal onlay mesh repair for a recurrence of an IPOM. So there were a few patients, one of them was this, where an IPOM was done in some other institution, and within about 1 year of the IPOM, the patient developed a recurrence very close to the original site of the repair. Being a very young patient, otherwise fit, she was keen that re-laparoscopy was done. And of course, with proper counseling and possibility that it may not necessarily be possible to complete the repair, I could do a re-laparoscopy, and to my surprise, in most of these patients, I found that the hernia happens at the edge of the sac, and a good dissection of all the adhesions with, again, cleaning up of the hernial cavity could be done with an IPOM plus like repair. So these patients generally did very well after the surgery. In spite of all that, when there was this discussion, I think Meenakshi will also remember that when there was this possibility of trying to put a mesh outside the peritoneal cavity, it always excites us, I think, as surgeons, that if something is going to be outside the peritoneal cavity, not bothering the bowel, it is something really interesting. However, after going through the technique of Ashwin, our very dear friend, I figured that it was a little too extensive for me with multiple monitor shifting and suturing, and so I couldn't go down that path a lot. But however, when e-tech came into vogue, it was something that appealed to the to the mind a lot, that you are going to be able to place a mesh outside the peritoneal cavity. And as of now, I am attempting to do ETEPs in umbilical hernias, which are about 3 or 4 centimeters wide, and trying to put this mesh extraperitoneally in patients who have very broad rectus abdominis, where you do not necessarily have to add a TAR, because I feel adding a TAR in these patients is a little excessive dissection. So that is the beauty of an ETEP, is what I personally feel. When it comes to complex hernias, though, if you have patients like this, where obviously the bad scarring and the unseemly scar and the exposed mesh, here by default your surgery is going to be that of an open approach, essentially. And in most of these patients, one can do a good retrorectus repair, a little bit of bridging if required for the anterior suturing, and most of these patients do very well without any additional TAR. Of course, if required, one can always add a transversus abdominis release, but that the requirement is very, very less. However, when you have patients like this, where there has been one TL followed by two or three ventral hernia repairs, two open and one IPOM, and when there is a clear loss of domain, you either need to get a botulinum toxin for the patient, or you try to establish a progressive pneumoperitoneum, as we tried in this patient. Unfortunately, in her case, it just pushed her into obstruction. It didn't work, and this surgery had to kind of be preponed to something like a semi-emergency procedure. And if at all there was any thought of doing a transversus abdominis, was given up, and a good on-day repair was done on her after adhesiolysis, defect delineation, midline closure, and ACST with a 30 by 30 mesh. This patient did well post-operatively. Now she's 22 months post-operative, post-COVID. She's asymptomatic and there is no sign of any evidence. And I had asked for a picture from the patient, and this is the recent picture that she has sent me. So, though there is a lot of scare about the facial, the necrosis of the skin, I still think that onlay is a repair that one can really do, and it's very helpful for such patients where there are comorbidities. And then there are hernias at difficult locations. So this is a 78-year-old patient with an iliac crest hernia, who had a previous radical nephrectomy followed by a laparoscopic cholecystectomy and a paraumbilical hernia repair done by open technique. Everything within the last 3 years. And now she comes to us with this hernia, and her complaint is that though it is a wide necked hernia, the bowel which is dragging into the hernia every time she stands up is really bothering her. So she was turned away by a couple of surgeons, but she was quite in distress. And after great discussion and deliberation, and though there was a talk of doing an extra ETIP for her, given her comorbidities, I preferred to do an open surgery, and I still found, even in open technique, very difficult retroperitoneal dissection due to her previous retroperitoneal surgery. So again, an onlay repair was done with bone anchors, and again, a little bit of flap necrosis was seen, but this is the patient 3 years down the line, and she's doing perfectly fine at 78. She's having a good whatever lifestyle that she wants, she has it. A similar hernia in a patient of a similar age but who is otherwise very mobile, with two laparotomies, one ileostomy, and then closure of ileostomy, and having a recurrence or having a hernia through this closure of ileostomy site. And these were the kind of adhesions. Now, this patient was very firm that he wanted a laparoscopic surgery, and I just hope all of us get patients like this. He just told me, "Ki, doctor, you please go ahead and operate on me laparoscopically, and I'm telling you, I will be fine and nothing will go wrong." He had a very, very bad defect with the previous mesh seen within the cavity. And again, after a complete adhesiolysis in this patient, a tape repair was offered, a transabdominal partially extraperitoneal repair. And at 5 years post-op, he's really doing fine at 82 years of age now. So same hernia, different patients and different approaches. Another patient with a very bad hernia with through a TL scar, and this is not the umbilicus. This is a mesh forming a sinus onto her skin. This was even before we were doing CT scans for such patients, and we found a nice punched out defect at the TL scar with the mesh entirely conglomerated at this site, and edge of the defect was fairly seen. And in this patient, it would have just been very the suturing of the muscle edges would have been under tension, and without component separation it wouldn't have been possible. So this use of the peritoneal lining itself as a bridge, which I was glad to note in the loss of domain conference, that there are people who really support this technique also. And it was used beautifully with an onlay mesh, and the patient got a beautiful abdominoplasty, and a little dog earring is something she was happy to accept. So I find that candidates for TAR are really very few and far, at least in my practice, uh, maybe because it's not a pure hernia practice. And I use hybrid procedures a lot. So especially again, patients like this with a battle scarred abdomen, 3 or 4 surgeries where you're not sure of how many defects you're going to get. Laparoscopy can be used beautifully for taking down all the adhesions. It's a wonderful way for dissecting clean the defects, and you find one defect in M2 or M3, and in M2, and you find another defect here in the lower abdomen. If you try to close them, either of the defects is going to cause a lot of stress on the other one. So either you have to do a component separation, or you can do a hybrid IPOM after completing the adhesiolysis. One can put a mesh inside the abdomen. I think Jyotsna ma'am had presented such a procedure at MassiveCon, if I'm not wrong. or one can go ahead and do an onlay, as in this patient we had to do because she was not affording a very large composite mesh. So these are the various options that one can exercise, or that is what I've tried to find. I mean, I have found out that one can use, but there are still challenges with every patient. Is what is the ideal procedure for this patient? That is something that one always wonders. And am I giving the best option for the patient, considering the patient's condition, lifestyle, expectations, or am I succumbing to the patient's ego, to the surgeon's ego or surgical ego? And have I given enough perioperative care? Because I found many of these, or most of these recurrences are usually happening very early post-operatively. Probably there isn't enough stress on the reduction of weight or dietary control or some kind of perioperative management. So that is a question that always bothers me, whether I have given enough perioperative care. And there are a few barriers where I still need to breach technically. I need to identify the perfect patient for TAR. I would definitely like to perform endoscopic TAR when indicated. And in the previously operated retroperitoneum, I would like to learn an ETEC, which I've tried 3 to 4 times yet, but I have not yet succeeded in them. So I feel we have to have our quiver full of arrows, and having a Brahmastra also will help to use in particular situation. And what is important is to align ourselves with what patients want rather than what we want as surgeons. And I'm going to end with this slide, because this is a picture that really, I think all of us female surgeons or any females working in the professional space all over the world, they identify with. But there is, the closer I look at this picture, I find that the men are looking ahead, but the women are looking to their right. So I feel that instead of doing that, we know these barriers that we have, which may be invisible to others. And what we need to focus on is on the end line rather than on what happens around us. Because gender discrimination exists everywhere. We all face it. It is a very social kind of a thing. So, for example, when a staff nurse from my OT, if when I point out to her that there is a change in her approach or behavior towards my male counterparts versus me, instead of saying, no, it's not there, if she happens to say that, oh no, I always tell everybody that you do such great surgical procedures in spite of being a woman, I somehow don't take it as a compliment. I take it more like an insult. So this is a very social problem in a patriarchal society which exists all over the world. When I came back from training in laparoscopic surgery, I was actually put in a unit where laparoscopy was not performed. Whereas one of the male counterparts, when he came from training, it was hinted that he should be allowed to do 50 gallbladders. So there are things that happen all the time, all around you. But if we keep looking to the right, we are never going to look ahead. And I would rather look at all the people that I really look up to, and uh, keep that focus rather than what is negative around me. And I would like to end with acknowledging my gurus in laparoscopic surgery, Dr. Dalvi and Professor Ed, and my entire surgical career, my colleagues at my department, who also make sure that I don't become complacent with anything, and our postgraduates who keep the light burning very high in us, bright in us all the time. And with the blessings of Lord Ganesha, who's going to visit us, and for which reason a lot of people are not going to attend this meeting today. I wish that he gives all of us his blessings and his wisdom. And I would like to end my talk. And I hope that I have not overshot time, Meenakshi. If I have, please excuse me.
Not at all, Aparna. You were very well, very much in time. Thank you for that
Thank
wonderful
you.
lecture. I think it was a beautiful journey that you made us accompany you in. And yes, I think even the comments upon the difficulties that because of the gender bias in a patriarchal society. I think probably one of the reasons for your success have been that instead of focusing on that, you just focused on growing. And I think that's the bottom line. If instead of getting into petty squabbles over who's benefiting where and what, you only focus on your own growth, you will achieve what you want, irrespective of how people around you are behaving. So kudos to you. Well done. That was a wonderful talk. Just a couple of questions, if I may, and then I think the floor can be open to anybody else who's wanting to ask. First and foremost, in your groin hernia repairs, is there any indication of going in for an endoscopic or transabdominal approach?
Not necessarily. So basically, it will depend upon the patient's condition. So if patients have previous appendicectomy scars or any other lower abdominal scar, I would prefer to go transabdominally. And if not, then obviously now the preference is a extraperitoneal approach. But when I was learning, I first learned as a TAPP, as a transabdominal procedure, because we are used to that anatomy and that just gave me a lot of comfort. And once that I was well versed with that, it is then that I shifted on to TEP, because I figured that either ways you spend time in TEP, you spend time during dissection. In TAPP, you spend time during suturing a little bit. So it finally balances itself out.
Balances out.
Yeah.
Okay. The second question is ki, has there ever been a situation wherein you have felt probably, or rather in complex large ventral hernias, where you feel that probably a plastic surgeon would do a better job?
Yeah, so actually I didn't show those slides because it was just becoming too much. But of course, there have been a couple of instances where, especially in one particular case where the patient had undergone previous massive blunt abdominal trauma. We had operated, there was an IVC tear that I had sutured, then a nephrectomy, and he had to be treated with an open abdomen with a mesh plasty. And thereafter, about 4 years down the line, when he came for his reconstruction, or actually those were the only cases where we really talked about reconstruction in those times. This was done maybe about 15 years back, and we had the plastic surgeon coming in planning a four-arm flap, so on and so forth. But even that patient finally could be managed with a good mesh, and he's doing fine even now. That was one instance, and one
Yeah,
more
I
patient when
think
there was a
those
spontaneous
those cases. Sorry, I think those cases look very challenging and probably very exciting. But I think there are far and few. The regular cases are far more, and it's important that for all practicing surgeons, irrespective of the gender, they be more comfortable and aware of the regular, uh, you know, uh, surgical options, the laparoscopic surgical options which are available for them. So thank you very much, Aparna, and over to you, Meenakshi. I think we can have the floor open for any questions.
Or we can directly go to Dr. Jyotsna and Barbara and then have the floor open at the end. Is that okay, ma'am?
I think let's finish with her lecture and
Yeah, I
then
think
we could ask questions to either of them. Thank you very much, Meenakshi. I'm very happy to be a part of this program today. And in fact, very proud and happy to introduce our young and dynamic surgeon from Prague, Czechoslovakia. Looking at her biodata, there is so much to say. She looks like the age of my younger daughter. And in that younger age, she has achieved so much. There are so many prizes to her credit. Basically, she has done graduation and post graduation in surgery from Czechoslovakia. And even her interest in hernia seems to be there right from that time, because she defended her PhD thesis, and the subject was use of biodegradable nanofilaments in the treatment of recurrent incisional hernia. So the hernia love starts there. Okay. Recently, she has been a clinical fellow in the Department of General Surgery in Edinburgh, And she was there for almost a year. She had just finished in August 2021. And to her credit, as I said, there are so many first times, or so many. She has been a winner of EHS research grant in 2019. She has been there's so much to read. I wish I had got this biodata earlier so I could have you know uh, and at the moment she has two fellows, research fellows, and she's supervising their PhD. And again, the subject has been biological substance diastasis of recti and its clinical significance. And the other one is expanding her previous PhD research on the nanofiber. Besides having so many publications and so many, she has won so many prizes. She's also interested in other activities, like she's been a good athlete and has won championship award in the sports for what is it, flat water kayaking. We don't even know how that is done, and she has won prizes for that. And at the moment, she has interested in running, and she has been one of the fastest medicos over half and full marathon distance. So over to you, Barbara. I don't think I've done justice to your biodata. I wish I could have talked to you earlier and I could have highlighted, the more salient features. But anyway, over to you. Thank you.
I'm very sorry. You must have been sent some very extensive CV of mine. I'm sorry for that.
No problem. It's good to know. Yeah. Maybe I think we could put it on our group because then people can read everything. Because I don't think I've done justice to what you're actually. Okay, so we, with your permission, we could put it on the group. Okay. Yes. Yeah. Thank you.
Should I just share my screen?
Sure.
Share the presentation.
Yeah.
Can you see it?
Yes.
Before I start, I would like to say thank you for inviting me. And I must say, I feel I've just become, I've just appeared in a group of absolute gurus and masters in surgery. And I'm extremely privileged that you ladies have decided to give me floor this evening, because it's a massive privilege to be in a company of people like you. And I feel sorry that this can't happen in person. It's in this virtual space. And I do hope that one day we will meet in person as well. I think my lecture is going to be very boring compared to the previous one, but I hope, or I have a feeling that I do actually come to a very similar conclusion. I come from Czech Republic. It's in the middle of Europe. Czechoslovakia actually doesn't exist anymore. We split with Slovaks in 1993, and it's just Czech Republic. It's quite a small country. If you look on the internet, you find a lot about it, but you shouldn't really believe everything you read about Czech. We're not really a dangerous country at all. But what is very sad is when you walk through the gates at the airport, this is the very first thing you see. And despite Czech being in the heart of Europe, this is how Czech men think that Czech women should look like, and this is their position in the society. They never say it loud, but this is very subconscious thinking, and you can feel it everywhere you go. And if you want to be a professional, you're absolutely welcome. We have all the EU laws in place, and there is so much done against discrimination. Yet when you go to your job interview, you get asked questions that no man has ever been asked. And this is the result of it. We have probably the biggest gender pay gap in Europe. And despite majority or slightly more than half of our doctors being women in surgery, where this discrepancy is very pronounced, only 10% of the staff are female. And currently we don't have a single professor of surgery. If you look at people or family life in the Czech Republic, less than 2% of men actually look after their kids to the extent of taking maternity leave, and less than 10% are willing to help with any houseworks. And that leads to something which I think is a crisis on the job market. And it's a sad fact that half of working women don't get back to work after having children. And that leads to a massive pension pay gap. So this is still a rarity rather than normality. And when you go for your job interview, as I said before, you immediately get asked about the small people. So you get asked, what are you going to do with your children? Do you plan to have any? And unfortunately, this is something which is valid worldwide, not just in Czech. And there's a significant proportion of people with psychological disorders among surgeons, and that leads to things like this. And this is not taken from Czech papers. It's taken from the internet and from the very few brave female surgeons that were actually brave enough to go to the press and publish reports like this. So for me, I think I have had this approach of not looking to the right, but looking ahead. And I have started an academic life hoping that in academia, the conditions are going to be slightly more fair and a little bit more transparent. I do come from a background of high performance sport, and it was who trained the hardest and who gave it the most ended up winning the competitions. And I thought academia is going to be the same, because my professional life definitely wasn't. And same like in training, you get hurt, it's sore, you feel hopeless, frustrated, but in the end you accomplish something. And my boss back then, he gave me a topic. We had a very big department of biophysics in the hospital, and they were looking for places where could they use the fibers they were making. They had a nano spider. It was the machine it's making nanofibers. And I was this average surgeon who was supposed to come up with an idea what to do with this. So I went to a hernia conference and I heard all about the mesh and how everybody has to use a big mesh and the biggest mesh, and all the smart dudes were speaking about their hernias and their meshes, and I was there and thinking, so is bigger always better? And I did some literature research and I looked that maybe the mesh isn't always the best thing in the world, and depends what mesh you use and which technique. And as we have seen in the previous presentation, mesh leads to adhesions, and sometimes these adhesions can actually ruin someone's life. So we have used this nanospider and we have created fibers which in the electron microscope, they actually looked like extracellular matrix. And basically we have hacked a biological mesh. We have made something which looked the same as biological mesh, but was a lot cheaper to make and took few minutes to produce. And the fibroblasts that are the green things seemed to like it. And we tortured not only just few cells, we also tried it on animals, and we have come with lots of samples and lots of experiments, and saw lots of slides in the microscopes, and then we published it. And this is how I got my postgraduate degree. And I was happy back then because I achieved something which was purely mine. I didn't get much help from my boss from it, apart of being given a topic and a phone number to another laboratory. I had to find all the money to do the research, all the people to do the research with. And I thought, this is not fair. But I actually, along the way, I have really, really enjoyed it. And it kept me sane. And it also kept me looking straight and not keep looking to the right or left and seeing if I'm being treated the same as my male colleagues or not. But what happened was they didn't really like it so much. And what happened along the way as well, because my topic was hernia related, I met my new family, the hernia family. And at least here in Europe, and I have a strong feeling it's very similar in India, hernia surgeons just stick together. And under the European Hernia Society, we're really a big family, and we meet on regular occasions, and we write guidelines together and travel to conferences. And I think we are each other's true family. And it was these people who actually helped me achieve everything I have achieved in my professional life. And suddenly I came home, back to my home destination and to my department, where for many years I was the only female surgeon. And I wasn't scared anymore. I was somebody who was quite confident in being myself and doing what I wanted to do. And when you don't look at others, but just follow your own pathway and your own journey, you do collect some success on the way. And it has happened to me as well. And this year we have started European qualification for abdominal wall surgeons, and I'm very proud to be part of the group that's behind it. In the department where I work, we have started a very thorough prehabilitation program, which was again done completely to the side of the surgeons. They didn't even know about it. And with few physiotherapists and a professor of sports medicine, we have developed a program which has improved the quality of life of so many of our patients. We have started to fill in registry, and actually to begin with, it was just me who was filling in all our patients into the European registry. And again, when I came back to my boss and I told him the results of our long-term follow-ups, he didn't want it, because he didn't like hearing it, because I was like this man screaming with a megaphone. It was not nice. When you start doing a thorough follow-up, you actually find all these mistakes you do. And after some time, I found myself a new boss, who's on the picture in the middle. He's really a lovely man. And he is a guy who doesn't seem to have a problem with women and surgery. So it's quite a few of us in the department, and these are my PhD students with the drinks. And suddenly things are not an issue anymore. So if there is the right mindset in the people around you, and if you are not shy and unconfident to be yourself, things are not problems anymore. So to go to a conference, to turn up with a small baby, it does cry time to time, and you might have to nip out of the lecture room for a few minutes, but it's possible if the people around accept it. And I was lucky enough to meet enough people who did. And last year I spent, I've actually only just gotten back from Scotland. I spent a year with Andrew DeBow, who's on the picture there, and with Ruth Hodgkinson, who is the beautiful lady next to him. She is one of the representatives of Medtronic. She's one of the marketing directors. And during COVID, we actually decided to have a baby together, and we have developed this online education program called Hernia Basecamp, which is on web search. It's free for everybody. And it's a textbook for anybody who wants to be a hernia surgeon. And we have just started this route to create a lot of hernia surgeons who will not feel bad because they are not seen as awesome or cool like all the transplant surgeons or robotic surgeons, but who will be proud of being who they are, and who will probably improve, or hopefully improve, outcomes of the patients, because at the end of the day, this is what really matters, and it's what patients want and what improves their outcomes. When you look at current numbers in UK, it's quite scary. You'll see that quite a lot of hernia surgery is performed by people who do very little a year, and it's probably what leads to some unsatisfactory outcomes. We've done a little survey on this topic last year. I've contacted every hernia self-help group that I could find, and when you look at the graph on the right side, you see that quite a lot of people are not very happy with the outcomes. So my current war is to introduce some pride into hernia surgery, because it's something extremely important and we do a lot of good in the world. On the other hand, this is early 20th century, and although people don't say that loud anymore, and I don't think anybody would say that I'm a two-headed gorilla, but still there is this mentality, and it's hard to beat. So in 2025, I'm going to organize a hernia conference in Prague. I hope that you will come, because it will be very much different to the standard conferences, and the theme of the meeting is out of the box. And I would like to bring some fresh air to surgery in general. Thank you.
Excellent talk, Barbora. It really shows your journey, not as just as a woman, but also as a hernia surgeon. And I think the very first topic which you had for your PhD thesis, as you said, you had to find out everything about how to go about, and still you produced a lovely thesis. So heartiest congratulations on that. Now, when I go back to your biodata, I think it will make a lot of sense to, whatever I have read or there. It has been a very inspiring journey. And I can see your little baby also is enjoying what his mommy is telling everybody. But he has been a good boy. Though he has been around, he allowed you to go through the talk. Okay. I don't have any particular question as such, but let's see what others have to say about you. So it's open to anybody who would like to find out more about, what Barbora is doing, or, what she's gone through. I think they're most welcome.
So I would like to start here by saying, like Dr. Jyotsna asked me that how do you know Barbora? So I remember her, from that one post in Facebook when we became Facebook friends, and you talked about how the situation in Czech Republic was at that time. And I thought, oh my God, somebody is expressing herself so well, and she has the courage to actually express it. And at the same time, as she said, that she has the guts to be a good surgeon, a good hernia surgeon, and to stand by her values. And also today I've discovered about you that you are not only a good surgeon, you are also an athlete, and you're a good mother. And something about her biodata, it says about that she's going to be working towards reducing the discrimination in the field of surgery, which is something very nice, because I think the biggest encouragement or kind of hope we are looking for, like when we look at Jyotsna ma'am, or when we look at Dr. Vandana or Aparna or Pinky for that matter, is like there are women out there doing it. So how they are doing it is by being strong and just being focused on what they have to do. So that is the strongest thing about her. And of course, she has been kind enough to respond to my messages, and she has stayed connected, and she has been kind enough to come and speak to us today. So thank you, Barbora.
It's not being kind. I'm extremely honored. It's such an honor to be in your company. Thank you. Thank you so much.
Yeah, I would like to tell one instance here. We think, at least we used to think, that the Asian countries, they give more importance to a boy rather than giving to a girl. But we were in England when I had my second child, and she was born late in the night. The next day, the sister in charge of that ward came to see me and the baby. And then she said, "What a lovely baby." And then she asked, "Is this your second one?" I said, "Yes." "So what is your first one?" I said, "She's a girl. She's a 3-year-old girl." I was shocked to see her face. She felt so sad for me. Oh dear, she's having 2 girls. She doesn't have a boy. And I was surprised, because in English, the British nurse was thinking that having two girls is something very pitiable and very sorrow thing for me. So that is still in my mind. My younger daughter, she's born in 83. She's your age. Okay. So I have still not forgotten those expressions on her face. And the same thing now you are repeating, though it is Europe, having a female surgeon who is competent, or I think a female in any branch for that matter, doesn't have to be in medicine. People take it, with a, they don't like it. And it's still continuing in this 21st century, which is really sad. But as you rightly said, if you're focused, if you want to do what you want to achieve, forget about what, it has to be like a horse with the, side, blinds on the side so that you're not distracted. You focus and then nobody can stop you. I think that is what we have to focus on, because there's no point in complaining that this is what people do to you. You do what you want to do and then you can achieve it. There will be more obstacles compared to what a man would face. But if you want to do it, you can do it. And you have shown it. Aparna has shown it. I think most of us who are, very passionate about what we are doing have shown these guts. And I'm really proud of that.
I think what helps is if you don't focus on yourself, but on helping somebody else, because that gives you a lot of strength.
Yeah.
Like for me, hernia surgery.
Question, Barbara? Yeah.
Sorry?
Okay, so just to deviate back towards academics, what sort of hernia repairs do you have a personal preference for? Are you offering the entire spectrum, or do you focus more on laparoscopy, or are you doing both open and laparoscopy?
No, majority of hernias I do are open hernias, because there is nobody else in the department who would do big incisional hernias and like recurrent incisional hernias, and majority of those we just do opened. I can proudly say I'm an IPOM virgin. I've never done an IPOM and I don't plan to start. I've actually been made to do one in Scotland, and the guy who was operating with me, I've convinced him that we have to cover the whole mesh by peritoneum, because I just wasn't comfortable with leaving it in after killing so many rabbits and seeing what the mesh does. I just I'm a big IPOM Protestant, I would say, but majority of operations I do are open. The groin hernias, I do TAPPs.
And what about groin hernias?
Yeah, groin hernias, we do mainly TAPP or open, because for some patients, laparoscopy is not an option, but I'm not a great laparoscopic surgeon. I have never been really given much training in laparoscopy. When I started, I was holding hooks on thyroid glands for about 3 years. So I absolutely hate endocrine surgery. And then I started to do lots of little things I could do myself. I consider myself a toenail expert. But hernias, I've pretty much taught myself from watching videos. There's lots of fantastic Indian videos on YouTube. Actually, majority of operations I have learned was watching some Indian tutorials on the internet, and going to conferences and speaking to people. And it's again something which the European Hernia Society encourages. You can apply for travel grant and you can go to some other center for a week, 2 weeks, however long you want, and spend time with somebody who teaches you something. And it's very much hands-on, and it's because in my department there is nobody I can really learn from.
Is that so in all over ZEC, or is it your hospital that people are not so much into laparoscopy for hernias? At other places?
Yeah, there are a lot of there's lots of laparoscopy for hernias being done, but it's mainly groin hernias, and I do them as well. There are some departments that do IPOMs for small umbilical hernias and things like this, but that's money laundering. I think they just do it for people who absolutely don't need it. They just operate on them. Sorry.
Okay.
And sorry.
Oh, that's okay. That's okay, Barbara. That's all right. But really appreciate your honesty and your candid confessions, and kudos to you for managing those complex incisional hernias. And I'm sure I'm sure you must be a fantastic open surgeon. So
I think Barbara over here in India, I think we are much more fortunate, though I don't think I should be complacent about gender equality or anything like that. But I read a report which was presented at the World Economic Forum at Geneva, and it mentioned that the globally to reach gender equality might take us something close to 196 years, sorry, 136 years. And when I read your email in sometime in between where they were planning to ban female surgeons from your association, or not pay you equally, I think these are conditions thankfully we do not face.
Yeah.
And as you very rightly said, that I also chose to remain in academics because it was giving me a very good chance to do what I like, and on an equal level as far as at least the payment and other privileges are concerned. So that is something, at least in India, we are fairly fortunate uh, to be maybe a little better than Europe in some ways.
I think laparoscopy has taken up so well in India, isn't it? Whether it's not just hernia, but even other branches. So I think we are lucky that I believe that all Indians are skillful surgeons, and we adopted to laparoscopy much earlier. So we are really fortunate, and I'm happy about it.
And we have very good teachers here. We are happy about that.
Thank you.
Yeah, we don't really have that here. You basically, if you want to be a laparoscopic surgeon, you have to deserve it first, and you get to do groin hernias and you get to do gallbladders, but that's it. Everything else.
Dr. JB, you want
Can
to
I
say
make
something?
a comment?
Yes,
Josna, can
please.
I make a comment?
Please, sir.
Josna, when we started laparoscopic surgery way back in India, it was almost 1991. And I would thank Dr. Lata Deshmukh, who was the dean of the Sion Hospital and allowed me to purchase laparoscopic instruments in a municipal hospital. That was the only municipal hospital that I purchased the laparoscopic instruments and started training. So in India, we are much more fortunate enough to start early,
Yes.
and the progress has been really tremendous. I'm so happy that India has progressed so well. In all nooks and corners of India, laparoscopy is being popularly done. And it is a surprising thing that in Czech Republic, they are, still trying and struggling to do laparoscopic surgery.
Barbara, I wanted to ask you something. In India, very few would be attached to teaching hospitals. So most of the people do private practice. And in private practice, there is nobody to stop you. If you have the will and the willingness to go and learn, and you can easily purchase the equipment for your own self. So what is the practice like in Czech? I mean, do you have private practice where you could decide that, okay, I'm going to learn, come back and do it? Because that has allowed us to progress, I feel. Because we are not under anybody's suppression. If you're not attached to any teaching hospital, sometimes that is an advantage. You don't have to depend on the institute to buy things for you.
Yeah, for us, we have the healthcare is free for everybody. So it's paid by the insurance company, which everybody puts part of their tax to. And unfortunately, surgery is very badly reimbursed because it's a fault. Sorry.
It's okay. It's okay.
Be with the baby. Yeah. It's true.
It's the ego of our bosses has kind of not helped us very much, because when they were making these codes, when the revolution happened in 1989 and we were suddenly a free country and we had free economy, they were saying, so how much should we pay for appendectomy? And they said, I don't know, 1,000 crowns, for example. And somebody would say, well, it only takes me 15 minutes to do it. And another surgeon would say, well, I'm better surgeon than you. It takes me only 12 minutes to do it. And like this, and they were arguing like this. And of course, the representatives of the insurance companies were listening to this. They said, fine. So we only pay you for 12 minutes of your time and one stitch, because that's what you need. And to change that, yeah, because these are people who are in their 80s now. A lot of them have grown up in this mentality where they had to constantly show off and they had to fight each other to be the best, and they have set a precedent, and a lot of time pressure as well. So we don't really have time when you're learning something. You're expected to do it immediately, quickly. You never get given time to do something slowly. So I have written a message to our Minister of Health, and I have met with him, and I told him, look, this is bullshit. You need to change it. And because he has a birthday on the same day as me, and he's actually 3 years younger than me.
Really?
So we actually found out we have a lot in common, and we have decided that together we can improve the situation, at least for hernia patients. I can't fight for everybody, but in hernia field, this is hopefully going to stop. For example, now for recurrent incisional hernia, my time limit is 90 minutes, and sometimes I operate for 6 hours. So for 4.5 hours, the hospital is paying for it, and it's actually losing money to do operation like this. So lots of other, the hospital is not interested in providing a proper operation. It's easier to do some quick fix, something which lasts 6 months, and because then they can charge again for another 90 minutes and things like this. And there's so many influences, and with laparoscopy it just takes long. My own boss, not the one who's on the picture, but his boss, who is still like Professor Emeritus, he still works there. He said to me, he said it into my face. He said, why would I train a woman? Because it's time and money wasted. And he says, if I have a choice between a man and a woman, of course I'm going to train the man. And there still are some guys who want to be surgeons. They're slowly running out of them. But the other thing is that in Czech, doctors get quite small salaries. I can say, at least compared to UK, where I was paid triple my Czech salary and I was on a training post there. While here I'm like, I finished my training, so it's to find good people is difficult, and the system is not very helpful.
The system is not helpful. Yeah. Okay.
No.
Yeah, I think.
So I think Aparna, you should feel better now. Don't you feel better now, Aparna, after listening to all this? The discrimination you have in KM or elsewhere is nothing.
No, I think we also face similar issues with our insurance companies that don't pay, us pretty well. But yeah, I think these issues are there everywhere. People want to train males or they want to hire males because they are going to be there for some time. Whereas with females, the first question is she getting married? Is she going away? So, a lot of such issues are just all pervasive. And I think we just need to raise boys with a more gender sensitive outlook, and maybe our resident doctors, and hope that this disparity will reduce over a period of time, certainly. And yes, you're right, ma'am. I think in an academic setup we certainly have a lot more that we get from the institution. I also consult in practice, so I know the probably the pluses and minuses of both.
Exactly.
But you're absolutely right that being
Both
in an
systems.
academic setup, it gives a wholly different flavor of life, and you get the same pay, so you can't complain. It may be less, but it's less for everybody.
Absolutely.
So we have a question for you, Barbara. What are the types of open repairs you do?
After spending a year in Edinburgh, I'm a complete convert to the peritoneal flap. It's actually a great technique and it's so easy. I went to some conference in London and I said there that it's so easy that even a female surgeon can learn it, and they were looking at me a bit funny, but they were only male speakers there. It was one of these menels that, you know, they just don't think that we have anything interesting to say. And I said, well, it's fine, very nice.
I think,
but I prefer anything retromuscular. If you need to do the TAR, I do the TAR. If I don't, I try to avoid it, because in the long term, they do come back with some other problems. And the peritoneal flap has actually convinced me, you know.
I think it's a savior. It's a savior. It's a
Yeah.
doable.
Yeah.
I think we have been doing this for like ages. As I said, there was a time when we would never do a CT scan for an incisional hernia or a ventral hernia.
Yeah.
You just assess the muscle tone of the patient and consider whether the bowel is going to hold inside or not. If not, you use a little bit of the sac. So much of the sac you are anyway going to excise and throw it off.
True.
So I am actually very happy to see that it is coming back, so to say, in a big way in hernia groups. But this is something that we have been pursuing, because especially in Indian abdomens, I don't know whether I can comment about everybody, but there is less protein intake as compared to Western cultures, and the muscles are not as tough many a times. In fact, they are flabby, thin, and the abdomen hold a lot. And the patient's expectation, because most of these patients are in a little elderly age group, so their expectations out of the repair are not really much, but that they can get around their daily activities in a good manner. They are not wanting to enter into any kind of an athletic or other activity. So I think it really works well most of the times, using a little bit of flap and bridging the gap a little bit. So I'm glad.
True.
I'm glad that it is being agreed upon.
You know what? I really envy you that you have each other, because for me here,
You are part of us now, Barbara. Okay?
What?
Yes.
You are part of us now. Don't feel lonely.
We are all coming to your meeting anyway.
Yeah.
But you have what we don't have here are role models. We only ever had one female professor of surgery, and she didn't have any family, she didn't have kids, so all the guys, of course, considered her as low grade, because if you as a woman fail to be a mother, there's something wrong with you, you know. This mentality. And she already died, and there is nobody, you know. All of them are men. We have a Czech Surgical Society that has 15 members of the board. They're all men. There's not a single woman. And we wanted to start just a branch to support each other, and they said no, we can start a knitting club. And it is because the thinking is so one-sided. They don't see what they don't even think that I'm right when I say that I actually don't like it when some of my patients or colleagues slaps my bottom at work. You know, you know, it's so bad. They think I should feel happy that somebody actually finds it nice and wants to touch it, and I don't, you know. And it's
I think Barbara, you give them one stern look, nobody will dare to do that, because now we have so many female surgeons. But when I took up surgery 35 years ago, there were a few surgeons who were females, and I was always surrounded by males. So at home, my sister-in-law would ask me, "You were wearing a nice dress today. Did anybody comment?" I said, "They better not comment on my dress or the way I am, looking. I want them to appreciate my skills," because there was a time when there were few female surgeons. Okay. But one stern look at that person who is trying to touch you will give him a lesson. He will not dare to do that. And then you shout it out and let people know that he's doing that. So he will be ashamed of him. This has happened to me, my colleagues. You know, under the table, we are sitting across, he's touching my foot from under the table. And, you know, you suddenly realize there's nobody who is sitting in front of you. And you loudly say, what are you doing, so-and-so? He will not do it again. You have to look in the eye and do it. You have to protect yourself because you are alone there. Now we have many female surgeons around us. But I have gone through this. Nobody will dare. She can't take things lying down. That's what they have to know. Okay? It's not nice. But there are people all over the world with a similar mentality.
Yeah, and then another thing is that the patients, they think you're a nurse constantly.
Yes. That
happens even here.
That happens everywhere.
In a conference, they will show me gynae instruments. they don't think a female could be a surgeon. Even today, after so many years.
Yeah, they come and they say, so am I going to speak to some doctor now? And think, okay.
Don't worry, go through this. Things will change. You're already doing brave things, so don't worry. But you have to show them their place. Just shout in front of everybody, what are you doing to me with his name? He will not dare to do it again. Don't,
don't be nice.
Yeah, don't be nice. Let everybody know what he's up to.
I'm not nice. I actually had to marry a New Zealander because I was so allergic to Czech men. So,
he's a doctor or no?
No. No, find a guy on the other side of the world and not a doctor.
You know.
Good for you.
Anyway, I think we will back you up, and whenever you feel lonely, I think we should add her on that group. I don't know whether she is WhatsApp allowed there. Do you use WhatsApp in your country?
She's in the AWR.
I am in the group.
You are in the group. Fine.
She's in the main group. We'll add you to the women's group.
Women's group. Yeah.
Yeah, I'm in that group.
Yeah. Great.
All right. So on that note, if there are no more questions or comments, I'll just take this opportunity to thank everyone who has been here, particularly our speakers and our moderators. Aparna, you were great. Barbora, very nice and so good to have you here. And Jyotsna ma'am, as always, you have inspired us so much, given us so much courage. And to all the rest of you who are there and who are supporting each other, the women and the men.
Sure.
Yeah.
They are our friends. They are our friends. They are not our enemies.
Not at all.
But if somebody is trying to pull you down, you have to show him his place.
Yeah, but they are very few in number.
Yes, very few.
I'm so happy to say that the men I have met as surgeons here are the best. And so thank you so much.
Yes.
And so we'll be having other meetings.